Chapter 6, Diagnosis and Treatment. As mentioned in Chapter 2, early childhood caries progresses through several clinical stages, from white line lesions to cavitated lesions, and finally rampant decay. Each of these stages is treated differently. The first step in the intervention for white line lesions is to educate the child's caregivers about appropriate feeding practices and oral hygiene methods to remove the biofilm from the child's teeth. Clinical attention is then turned to the white line lesions. Special care must be taken not to cavitate the lesion with the explorer during the examination, because cavitated lesions require restoration. For infants and toddlers, the clinical intervention for white line lesions is frequent fluoride varnish treatments. A number of fluoride varnish application regimens have been proposed for these high-risk children. These applications vary in frequency from 3 times a week to once a week for 3 weeks, once a month for 3 months, or every 3 months. Clinical judgment should be used and the caries risk assessed before one of these or another application regimen is chosen. Parental education can also be reinforced at these application appointments. Now let's turn our attention to the treatment for a child who has 1 or 2 cavitated lesions. Again, the first step is to educate the parent about appropriate feeding practices and proper oral hygiene. Next, the children are treated in a knee-to-knee fashion with the parent, as described earlier. Local anesthetic for lesions of this size is generally not needed. The area of decay is removed with a round burr in a slow-speed handpiece or spoon excavator. Glass ionomer is used as the restorative material. This method of treatment is called the interim therapeutic restoration and is best used as part of comprehensive care in the dental home. It is our hope that many dentists who treat children would be able to accomplish this treatment.
There are some situations where it's appropriate not to treat a child who has a frank area of decay. We have to measure the child's behavior against the urgency of the situation. If a child has a small treatment need and their behavior and their cooperation will improve over the course of the foreseeable future, we can postpone treatment for a period of time. However, if the child has an urgent situation, such as they're in pain, they have a large treatment need, they've had a traumatic injury, those children require immediate treatment.
The American Academy of Pediatric Dentistry has this to say about delaying treatment. When a child's behavior prevents routine delivery of oral health care using basic guidance methods, the dentist must consider the urgency of dental need when determining the need for immediate treatment. However, the Academy cautions that rapidly advancing disease, trauma, pain, or infection usually dictates prompt treatment. The decision to delay treatment is always a difficult clinical judgment. This is an example of a 19-month-old child with a treatment need that may be restored conservatively with the IRT method. 60 days later, however, this child's disease has progressed to the point of needing stainless steel crowns. It is not uncommon for general practitioners to feel they cannot accomplish stainless steel crown restorations on a 21-month-old or a child with significant treatment needs. In this case, the child should be referred for treatment. The Academy has this to say about such cases. To perform treatment effectively and efficiently while instilling a positive dental attitude, the practitioner caring for a child with ECC often must employ advanced behavior guidance techniques. These may include protective stabilization and/or sedation or general anesthesia. Therapeutic intervention for children with early childhood caries should be provided by a practitioner with the training, experience, and expertise to manage both the child and the disease process. Occasionally, children will have no clinical evidence of dental disease. If the spaces between the child's posterior teeth are closed, the examination is not complete without radiographs. While this child had no clinically evident disease, radiographs display multiple areas of proximal decay. Clinical signs of proximal decay generally indicate that the disease is advanced. At this stage, treatment is critical in preventing the disease from entering the pulp and leading to facial infection.